with the Community Health Training Institute. I'm really excited to be one of the co-trainers today, and I get to talk to you about history, which is my favorite. So we'll get to that later, but welcome to all. And I will pass it to Jasper.
Yeah, good morning, folks, or afternoon, wherever you're based. My name's Jasper. I use they, them pronouns, and most important for you all to know today is that I will be your tech support. So if you run into any issues with Zoom, feel free to reach out, let us know. I'll do my best to help you. I can't promise a solution, but we will try our darndest. And with that, I will pass it to Kelly.
Good morning, everyone. My name is Kelly Dankert. My pronouns are she, her. I'm a program manager at Health Resources in Action, and I'm based in Central Vermont. And I work on CHTI, but also on the Massachusetts COVID-19 Community Grants Program that we're highlighting as an example and case study later on today. So I might be popping in to comment on that. And with that, I'll pass it over to Lauren.
Thanks, Kelly. Good morning, everyone. Welcome. My name is Lauren Bard. I am the newest member of the team. I've been with Health Resources in Action for almost a month now. I am a training manager and here today in the role of moral support and to learn alongside everyone else. And am I passing it back to Gina?
Yes, I'm happy to take it back. Thank you, Lauren. So again, for those of you that are just popping on, welcome. We are just getting started. Again, my name is Gina Rodriguez. I use the she, her pronouns. I forgot to say I am based in Central Massachusetts in the city of Auburn, although I was born and raised in Boston. I'm coming to you from Central Mass today. And so I noticed in the chat box, we have folks from all over the place. I saw some folks from Malden and Springfield and Plymouth and Puerto Rico and New Mexico. What else do we've got going on over here from all over the place? Did I miss anybody? Let's see. If you haven't already, please feel free to drop your organization and roll into the chat box just so we get a sense of who's in the room and where you're coming from. So you're here for the role of public health in pandemics, and we're going to be here till 1 o'clock. We will have a break later today, just so you know, but we're going to keep the train moving so we can make sure that we end on time for you all. All right, so we can go to the next slide. And just a quick Zoom overview for those of you all that are probably, or that might not be as familiar, although that's probably few and far between nowadays. But there are all these buttons that you can use to interact with Zoom and this training today. We are really intentional about making all of our trainings interactive, and creating spaces for you all to connect and join the conversation. And we do that in a couple different ways. Some of you are already chiming in on the chat box. It's a great way for you to drop information, share resources, ask questions. If you need tech support, as Jasper mentioned, feel free to drop any and all of that information in the chat box. And that's one way that you can engage with the training. You can also unmute yourself and join the conversation. And so there are going to be some spaces where we have large group discussion and we'll ask you, what do you think of this? How are you, is this resonating with you? How do you see this playing out in your work? And we invite you to unmute and just join in. Sometimes that can feel a little bit scary on Zoom when you're looking at boxes of faces that you don't really know, but we try as much as we can to create community here and welcome you to bring your own voice and perspective into this space as well by hitting that unmute button, as well as sharing your video as much as you can. We love to see your faces, to see your reactions to the information that we're sharing, the questions that we're asking, the corny jokes that we're making. All of it is welcome. And especially when we do breakout rooms, which is another way that we try to engage you all, is that so other folks can see you when you're in breakout rooms. But with that being said, we recognize that some folks don't have camera access or don't want to have their camera on. And so we recognize that as well. Do what you need to do to take care of yourself as well. But we love it all. Some of the other ways that you can kind of formulate your screen is on the right-hand corner of your screen. You can switch your view. So you can switch to gallery view and see other faces, speaker view, and kind of play around with that as well. As I mentioned, we're going to be doing some small groups. So you'll be placed into small groups to do some smaller conversation. And then we're also going to be using something called a Padlet today. So you all can take notes, interact, and share, and we'll be using a Padlet to share some information as well. So when those opportunities come up, we'll sort of guide you through that in case you've never been in a breakout room before and never used a Padlet. But if you have any questions, as I mentioned, drop it in the chat box. That was a lot of information very fast. So I'll pause here. Continue adding your name, role, and organization in the chat box as well. We welcome that. All right, so I think we're ready to go on to the next slide. This is all about using breakout rooms. Again, we'll sort of guide you through it when the time comes. We're actually going to do some introductions in breakout rooms today. But when all else fails, if you run into any problems when you're in a breakout room, there's a little button that says ask for help. And all you have to do is click it and one of us will go in and help the room out if you need anything or have any questions. Next slide, please. This is all audio stuff. So for those of you that are having trouble with your internet, or if you find that you have low bandwidth and you're getting a little bit glitchy, you can switch your audio to your phone and just use your computer for your video. And so if you hit the little arrow next to your mute button, there's an option to switch to phone audio, and it gives you a phone number that you can call and a PIN as well. So that's an option for you if you're running into any sort of lagging or internet issues. Awesome. These are our learning objectives today. And so this is what we hope to accomplish by the end of this training, that you'll be able to understand the history of public health, especially as it pertains to epidemics and pandemics and disease outbreaks. We want to explore a timeline of public health to make connections between the past and the present, and then identify some public health strategies and tools that can be used to address threats to health. And at the end of this training, we're going to give you a feedback form, and we really want to hear about how you think we did. Did we meet our objectives? Did you feel like you gained some information from this training? And then we use all of your feedback to inform all of our training calendar for next year. This is around the time of the year that we start to think about what we're going to offer for next year. So your feedback is really valuable. So we ask that you stick around at the end to fill out our feedback form as well. Next slide, please. And then our agenda for today, right now we're going over welcome and introductions. In a second, we're going to do some group agreements before we do some small breakout rooms. And then we're going to get into public health history and talk through what that has looked like over the years, what we've learned from it. As I mentioned, we will have a break in the middle, and then we'll get into some of our best practices and strategies by looking at the COVID-19 project that we have here at Health Resources in Action before we close out for the day. And again, we're slated to be here till 1 p.m. Eastern Standard Time. Next slide. And then the last sort of chunk of this welcome and introduction piece are group agreements, the way that we kind of hold space together. And we ask every group that we meet with if they're okay with these agreements as we hold them, and I'll read them and kind of share them with the group. Is if you can, leave your camera on. Again, do what you need to do to take care of yourself. But if you can, we love to see you. Mute yourself if you're not speaking. Pretty self-explanatory. We just want to minimize the background noise. And if you are muted by one of our hosts or co-hosts, please do not take it personally. Again, we just want to make sure that we're minimizing the background noise and you can hear the folks that are speaking. We also have on here take space and make space. Is really all about bringing your voice into the room, making space for others to share and taking space yourself and paying attention to how much space you're taking. Are you talking a lot? Do you need to make room for others? Or are you not talking at all and you want to kind of make space for yourself to step in and join the conversation? Respect yourself and others, whatever it is you need to do to take care of yourself. I think those two are very much connected, and respecting the voices and perspectives that come into the conversation in this space as well. And then the last piece here is really about confidentiality, sharing the lessons and not the details. So whatever you hear here, all the lessons that you learn, taking it with you back to your work, but leaving the details behind in terms of confidentiality. So that's kind of our our list of group agreements. Is there anything here that folks feel like is missing that we want to add to our group agreements as we hold this container in space today? And if there's anything you want to add, you're welcome to unmute yourself and add, or add it to the chat box. And I'll give it a second for that kind of to land. All right, so I'm going to take the silence as we're good to go. So if you are in agreement for these agreements, I'm going to ask you to put your thumb up, actual thumb, or feel free to hit one of the reactions on the bottom and let me know that these agreements sound good to you and you're ready to get started and you're excited and happy and ready to get trained. I'm also like attempting to bring my own energy up. I'm waiting for the coffee to kick in too. Awesome. All right. So we are officially going to get started with introduction so you can get a chance. Thumbs up. I love it, Barbara. Thank you. So you can get a chance to talk to a couple of other folks in the room as well. So I'm going to ask Jasper to take us to our next slide. We're going to do our first small group. So if you haven't, in the chat, please feel free to share your name, pronouns, organization, and your role there. Lots of people have been dropping their information, which is awesome. We love to see it. And then in a second, we're going to split you into smaller group conversations. You'll get a chance to introduce yourself to folks in the room and share a fun fact about yourself, whatever you feel okay sharing in a group of people, just to get to know who's in the space with you and who you're going to be having conversations with as we move throughout this training. Does anybody have any questions about that? It's really just to say hello and get a chance to talk to other folks in a smaller group setting. Does that sound good? Awesome. Thank you, Tanaya, for adding those instructions in the chat box. You will be able to access the chat box in your breakout rooms if you forget what you're supposed to be talking about. But Jasper, when you're ready, you're going to get a little pop-up that brings you to your breakout room, and then you'll be switched away for about 10 minutes or so. So that pop-up should be up on your screen. And when you're ready, hit join. All right, I think all of our rooms are back. So welcome back, everyone, and welcome to those of you that just joined us. Hopefully you got a chance to introduce yourself and say hello to a couple other folks. I would love to hear if there are any interesting fun facts that folks want to share with the large group. Feel free to unmute yourself and share your fact or drop it in the chat box. I'll take either one.
Hi, my name is Jessica. I'll share. I'm in Trenton, New Jersey. I was in a group with Damien and Dora, and the three of us had some type of connection to the state of Massachusetts. And then we briefly talked about gas pumping. So I live in New Jersey. We do not pump our own gas. And then I think Oregon is another state where they do not pump their own gas. So that was our fun fact.
I love it. Yeah, we've done road trips to Jersey to visit friends. And that's one thing I enjoy about visiting Jersey is I don't have to get out of the car, especially when it's winter and cold. Any other fun facts that folks want to share in the large group? Just to say hello and bring their voice into this space. Something we found out yesterday as an organization. So within our organization, we have departments, and our training and capacity building department just happened to have, I think, up to five or six folks that are born in May and within like 2 to 3 days of each other. So we're a tourist friendly place here at Health Resources in Action. So if there's any May birthdays, we love you here and we welcome you here. Mine is on May 3rd, and I have a birthday twin here at the organization, which is fun. Awesome. All right. So I think I am ready to hand it off to Tanaya to officially get us started. Just want to welcome you all again. Happy to have you here, and I will hand it over to Tanaya.
Thanks, Gina. Just have to throw out some Aries love if there are any other Aries in the room, because it's, I think, officially Aries season. So just wanted to lead with that. Awesome. So welcome all. Super excited to be getting going. So we're actually going to start off with a poll. So Jasper, when you're ready, we're going to go ahead and launch a poll. And the question you're going to answer is, what is public health? So very basic, straightforward. Just want to get a sense in the room of what do we think this is when we say, what is public health? Give you a moment to answer that. We're at like 76, 78%. If we could get to like 95% participation, that would be awesome. Give you another 30 seconds to think about it. Maybe like 1 or 2 more people. All right, beautiful. I'm gonna go ahead and end the poll. Let's see, if I click share results, can y'all see that? Is everyone seeing it? Yeah, okay, great. I can never tell when we're on the back end, we're like, can people see this? I don't know. So excellent. You all nailed it. 100% of people that answered the poll picked the right answer. So if we can just move into the next slide, please. Could I get someone to read this out loud? This formal definition. Can someone speak that into the room?
I'll go ahead and go.
Thank you.
So the formal definition is that public health promotes and protects the health of the people and the communities where they live, learn, work, and play. But practically speaking, public health focuses on the treatment of communities and populations and intervenes to prevent further harm using a variety of methods, focusing on the upstream.
Beautiful. Thank you, Ashley. So why are we starting here? This training is going to tackle some big events in the history of public health, but we weren't sure who was going to be in the room today, and we don't want to make assumptions about where we're all coming from in terms of our understanding about this field. So I thought it would be helpful just to kind of ground us in this both formal and like really practical definition. So we're not just talking about, for example, medicine, right? So we're not focusing solely on individuals or on individual health, right? We're really thinking about communities and about populations. And even more, we're thinking about interventions. We're thinking about harm reduction. So strategies that really get at protecting populations as a whole. So we just wanted to name that. So things like, vaccinations, things like seatbelt laws, things like tracking diseases and their impact. So these are all the things that are going to pop up when we kind of dive into the timeline in a moment. So I just want you to keep that in mind. So this is a really broad field. It's a really broad definition, but just keep that sort of global population level context in the back of your head. Awesome, thank you. And I think we had a quick logistical question. I just saw it pop up, Gina. Is there a phone number that we're not sure about?
Yeah, there's a phone number in the room, and we just want to make sure that it's not attached to anybody's video. So someone's like in a video of a breakout room and their phone is not attached. So if your phone number is 413-209-2932, let us know so that we can make sure that you get to the right place. And if you're having any trouble, please feel free to unmute yourself and just say hello.
Cool, awesome. So yeah, if that number is yours, feel free to let us know in the chat just so we can make sure that you're able to hear us and participate as you're able. Awesome, so let's go ahead and jump to the next slide. And actually, I think this is where we're going to open the timeline. So I will pull that up, and Jasper, I think you can stop sharing, but if you don't mind just sharing the Padlet link in the chat, that would be awesome. Will I get this up? See if Zoom will cooperate with me today. Okay, where did you all go? There we go. Okay, so can I get some thumbs or nods if you can see this public health history timeline? Just want to make sure we're all looking at the same thing. Great, awesome, love that. Wonderful. And you're also welcome to follow along on your own. Jasper just stuck the link in the chat box if that's easier for you, whatever is most comfortable for your learning style. So just move you over. Sorry, I'm not used to being on my two monitors, actually. I'm used to being on my one screen, so sometimes moving things around takes me a moment. But I'm almost there, I promise. We're going to dive right in. Here we go. Awesome. So looking at this timeline, right, you're probably looking at that number, 10,000 BCE, and going, why are we starting like way back when in this like really ridiculously long ago time period? And the answer is, I wanted us to take a really global view of public health. I think a lot of times we come into these spaces thinking about public health, and it's very Western focused, it's very US focused. I didn't want to do that today. I really wanted us to dive back into like eons ago and think about the very beginnings of what we call public health as a field. It's not new, you know, it's not a Western invention. These practices, things that we would call public health practices, have been around for thousands and thousands of years, really since, and I started this here with the Neolithic or first agricultural revolution in 10,000 BCE, because this is sort of where we make the shift from living as hunter-gatherers primarily to living in towns or in cities, living together, not moving, not migrating. And so what happens when a lot of people get together in the same area? What do we get? Anyone, throw things out in the chat out loud. What happens when you get a lot of people in one space?
Germs.
Yes, thank you, Chelsea. Absolutely, we get germs, we get disease, right? It makes it really, really easy for things to spread when you've got a lot of people in the same place. So that's why I'm starting us here. So the next couple of boxes, let's see, 1, 2, 3-ish boxes, are sort of that like not prehistory, but like really, really ancient history as related to public health. So Hammurabi's Code. Has anyone ever heard of an eye for an eye? I'm seeing some nods. Yeah, so that's where this comes from. So this is one of the first codes of law that was ever written down. It was written in this ginormous stone tablet by Hammurabi, who was a king in Babylon. And a lot of it really focused on things like property rights, marriage laws, women's rights or lack thereof. But there was also a couple of things in there around health practices, right? So even way back when, 1700 BCE, we see things written down about how people should conduct themselves to make sure that the community stays healthy. We see something similar if you look at ancient China, ancient India, the Incan civilization, ancient Egypt. These cities and towns were equipped with things like sewage drainage systems. They had, you know, public baths, these different sort of amenities, sanitary amenities, we would probably call them, that were really deeply tied in a lot of these places to religious belief systems that really kind of married the ideas of health and hygiene with divinity. So these things were existing way back when, like long before the US was even a twinkle in anyone's eye, right? And these measures really evolved with the development of urban societies, which I think is super cool. So you can do some extra reading if you're interested in that stuff. Happy to send you things. I told my team, I was like, you have to rein me in because I will talk about this for an hour. I love this. I was a history major. This stuff is awesome. But I digress. Okay. So then we kind of jump into classical Greece, and they actually, I don't know how many folks are familiar with this, but they knew what malaria was, so they experienced it. And they were able to even kind of narrow in on the fact that it was connected to climate, right? And they could tell that it was spreading between people. They didn't know how, right? They didn't know exactly what was happening, but they could tell that like when someone was sick and they came into contact with someone else, like those people got sick. And so they put sort of as a result, a really high emphasis on healthful living habits. So I know this is not technically public health, but like the Olympics, right? That emerged out of ancient Greece. Like they were athletes. They were really focused on staying healthy. and keeping each other healthy. So nutrition, hygiene, physical fitness, community sanitation were all key components of ancient Greek culture. So I'll pause there. Any sort of reactions to this first piece, this sort of ancient chunk of time? Questions?
I really love the fact that you did not start with the cholera epidemic with Jon Snow. So I really appreciate that.
Thank you. Okay, we can keep going. Feel free, as things come up, you can actually comment. I forgot to mention that. You can comment on this Padlet. So if you have questions, if you want to add something, feel free to do that or throw it in the chat. I'll do my best to make sure I'm checking on that and not just going on and on about these different things. But the next sort of chunk of time is going to get us to the Black Death. So we have the rise of Christianity, right? And I'm ballparking it at around 400 CE, because that comes just a little bit after Emperor Constantine declared Christianity the official religion of Rome. And this is sort of when we see health and illness not necessarily being linked to divinity, but being linked to sin. So we get things like, witch hunts, right? So why are people getting sick? Oh, it was a witch, right? Or sort of the expulsion of like lepers from their communities. So really this idea that people who are sick or people that are bringing disease are like fundamentally evil or immoral. And I sort of paired this with this next box. So the Umayyad and the Abbasid caliphates. Is anyone familiar with this time period? Kind of searching for any other folks. Okay, so I won't go too much into this, but essentially these were two really powerful caliphates, powerful dynasties that primarily ruled in North Africa, in southern Spain, and in Central Asia, Islamic empires. And they encouraged the flourishing of health knowledge. So while we have the spread of Christianity and sort of this linking of health or illness to a moral failing, on the other side, we have at the same time, roughly same time period, these really powerful and flourishing Islamic caliphates that encourage this knowledge. And I think I included this primarily to share one of my favorite historical facts, which is the House of Wisdom. So I don't know if anyone's familiar with that, but it was essentially this really amazing space of learning. Think like a library or like a scholarly kind of, not exactly a university, but a place where scholars could come and learn and share knowledge. And they had a lot of knowledge. They had things from way before their time on health, on medicine, on science. And unfortunately, the House of Wisdom was sacked and burned down in 1258, which is devastating. But just to name that, like, while, we have things like the Black Death, which I'm going to jump into in just a moment, happening in Western Europe, in Southern Europe, in Central Asia, in Africa, we have sort of the opposite, right? We have this flourishing of knowledge around health and community health. So just wanted to name that. So the Black Death, we're all probably pretty familiar with this, right? This is sort of the next chunk of time before we move more into the mid 15th, 16th, 17th centuries. It was devastating, right? So approximately, I think historians estimate up to 2/3 of Europe's population was wiped out. I think what doesn't get talked about as much is that that happened across the globe. So this actually started in the East. It was able to spread along the Silk Roads, along other trade routes, eventually reaching Western Europe and essentially wiping out like over half of the populations everywhere that it went. And I think the Black Death is also really interesting because of the public health measures that we see taken. So I don't know if you've ever seen photos of those like plague masks before. So those are actually real. I don't know if y'all knew that. I had a professor in college actually who had an exact replica of a plague mask, and she wore it to class one day and it was ridiculous, but she was like, yes, this is what people actually wore, doctors actually wore when they visited patients. So even back then, they weren't very effective, but they had masks, right? They had quarantine laws. There were plague hospitals so they could isolate patients. Unfortunately, they didn't have the medicine to deal with it. Communities were often small. There was a lot of contact. The disease spread very quickly. And a lot of times they would put the bodies outside of the city walls in hopes that, you know, the disease wouldn't get to them. But unfortunately, that didn't really work as an effective measure. But they were thinking about these things, right? Even back then in 1346, they had some idea of how disease was spreading. I think the other thing to name here, and we'll sort of get back to this later, is there was a lot of scapegoating. And particularly, I think Jewish folks were often blamed for the spread of the plague, other groups as well, but I think that was sort of one of the more prominent ones. So just naming that even back then, right, if things go wrong, someone gets blamed. So we see that today, COVID-19, right? There's been a lot of anti-Asian violence. People get scapegoated. So keep that in mind as we move forward. This next box, the age of exploration, colonization, I'm going to come back to this. I just wanted you to note where it is in the timeline. So we're going to talk a little bit about what we would probably call an epidemic of Indigenous and Native Americans in both North and South America who were decimated by disease. But I just want you to keep in mind that it wasn't just disease, right? There were social conditions at the time that were playing into the super high death tolls that we see. So just want to note where that is. I promise we'll come back to that. There's a lot more to say. I'm going to pause again. Any questions, any comments before we jump into the next section of this timeline? Okay, awesome. So next we have sort of the Enlightenment, and then we're moving into the age of vaccines, for lack of a better official term. So the Enlightenment, right? We have scientific advances. The microscope is invented. We have lots of mechanization of labor, which paves the way for the Industrial Revolution. This is all good in theory, right? We're making it theoretically easier for people to do things. We're getting these new advances. We're getting new ways to kind of, you know, reduce the human risk for some of these different jobs that people were doing. As a consequence, though, I think it's important to point out that the Industrial Revolution and sort of this building of urban centers, as we really think about them today, really made it easy for diseases to spread. And Damien, you mentioned cholera, right? So this is part of that wave. Is because people were living in close quarters. There was really poor sanitation, no laws, no regulation really of human rights in terms of people being sent into factories, children being sent into factories, right? So we get a lot of disease outbreaks, we get poor sanitation. And I think this is important to keep in mind because the Industrial Revolution is sort of where a lot of historians kind of mark like modernity, which I could argue with, but just thinking about like how our world looks today, like this is kind of where it's starting. And so the public health practices that we're seeing today, in a lot of ways, are emerging out of this movement. So just wanted to name that. And then we get the smallpox vaccine. Does anyone know this story, actually? I never tell it very well. So does anyone want to share this story of how we got the smallpox vaccine? Anyone who's really familiar?
I can try my best.
Yeah, please.
So I forget his name. I do believe it's Jenner. So Jenner had noticed that milkmaids that were working with cows seem to have been actually immune to the smallpox. Not understanding why, but when milkmaids are pressed up against the cows to milk the teats, the porous hair of the cows actually presses into the skin. And if they do have a pustule on their body, the milkmaids were actually getting the pus into their skin. And so Jenner had noticed that there was a correlation there. So he started taking the smallpox from the cows, and then, of course, unethically, started to inject children to see if it would work, and then put them in crowds to see if they would actually be immune. And it turns out that it actually was. So that's how the smallpox vaccine came about, because accidentally realizing people who are milking cows were immune, and then actually putting it into the community to see if it created any type of immunity.
Beautifully said, yeah. And just to add that this sort of emerged from this process of variolation, which I had to do a lot of research on because I'm not gonna lie to you, I did not understand what the difference was, but apparently variolation is actually very specific to smallpox. What they used to do is they would take like scabs or like rubbings from a pustule and like blow it up people's noses. And then they get a really mild case of smallpox and then kind of develop immunity afterwards. This was a jumping off from that practice, which actually I think originated in China. So wanted to name that. And then also just to add, vaccination, this is kind of the first time we see it being adopted on a wider scale. So I think during the Revolutionary War, we saw variolation was used quite a bit. So George Washington required all of his troops to be variolated. That sounds like a fake word, but I think that's right. And in the 1800s, early 1800s, the British Army and the Danish Army both adopted vaccinations. So again, this critical public health tool is kind of emerging at this time. Around the same time, we have the cholera pandemic. I won't speak too much on this since it's been mentioned a couple of times, but just to note, it starts in the 1800s, really in India and spreading through Southeast Asia. It hits Western Europe a little bit later. And this is where we get the story about Jon Snow and shutting down the water pump in London and protecting people from getting sick. So I'll keep us moving. I just got my 5 more minute warning to wrap this piece up. So keep us going. So the next couple, I won't spend too long on, but just to name. So we kind of see the first National Sanitary Convention. So that's pretty big, right? So actually trying to codify what we mean when we say quarantine procedures. We get penicillin in 1928, which is obviously a huge win for protecting human health. We see lifespans like rapidly increasing with these types of inventions. I'm skipping over the influenza pandemic because we're going to come back to that, but just note that it kind of comes between these two things. So before penicillin is invented and after, we're sort of trying to codify some of these laws. In 1948, this is post-World War II, we get the WHO, or the WHO, I guess. I always say WHO, that's probably wrong, but the WHO is established in 1948, along with a couple of other really long-lasting global efforts. So the United Nations, the Geneva Convention on War Crimes, the Genocide Convention, that all kind of emerged after this really horribly devastating World War. And this is important because this really marks the globalization of public health efforts. This is the first time that we see various countries coming together and saying, how are we going to fight these diseases, right? But again, when we talk about this stuff, we have to think about equity. So who was at the table, right? It was Western nations primarily. And I want us to keep that in mind because we see this sort of thread coming throughout. Who is being prioritized, right? Who is making these decisions? 1955, we get the polio vaccine. I don't know too much about how that works necessarily. I'm not a disease expert, but it's really effective. And it was kind of one of the first times that we see a vaccine that was able to be pushed out to even sort of the more hesitant folks who maybe didn't want it as much. And while polio is still a problem in some other countries, it was considered eradicated in the US in 1979. I think the only disease, and you all can correct me if I'm wrong, but I think the only disease that's been officially like worldwide eradicated is smallpox, and that came in 1980. I'll sort of skip over this next box a little bit, but just to name that sort of narrowing our focus in, since we're going to talk about COVID-19 in the US context. In the 1950s to the 2000s, we see a lot of wins and losses. So we see things like the Clean Water and the Clean Air Act. You get the environmental movement, the civil rights movement. And on the flip side, we see a lot of really nasty things, right? So with the AIDS epidemic, there was a lot of blame placed on gay and bisexual men for this disease, right? It was seen as really dirty. It was said that, you couldn't touch somebody with AIDS without contracting it yourself, which of course we now know is not true. We see the war on drugs that comes later in the 80s and 90s that really targeted Black and brown communities, and those effects continue to this day. And then we jump into the present, right? 2020 to 2022, we're in the COVID-19 pandemic, it's ongoing. And I said here, wins and losses for public health efforts, because again, we could talk about this forever, but I wanted us to kind of stay focused and not get too lost in the weeds here. And we're gonna get a chance to kind of dissect that a little bit more later today. I'm gonna pause because I just talked at you for like 20 minutes. Do we have any questions, initial reactions, thoughts, things that I missed, things you want to name in this timeline? I'll give you a chance to do this in small groups as well, but just wanted to make sure I don't miss any kind of initial gut reactions. Thank you, Dora and Vanny. And I'll take this moment before we dive into breakout rooms just to name that, and I'm probably going to sound really pretentious, but I'm definitely a proponent of the idea that history doesn't actually repeat itself, but we can definitely learn from the patterns and the processes that emerge throughout time. So while I don't think we can necessarily compare things apples to apples, I think there are some really important lessons that we can take from some of these events and from some of the pandemics we're going to talk about in the next section to think about how we reacted to COVID and what we can do moving forward. Because, you know, not to be depressing, but this is not the last pandemic, right? This is not the last time this is going to happen. So I'm going to leave you with that, and we're going to dive into some breakouts for about 10 to 15 minutes. So I'll stop sharing, and I don't know if we need the slides, but maybe let's just pop the questions in the chat box, if that works. Awesome. So we're just going to think about, what is this story telling us? What is this timeline telling us about public health as we see it today? You can also react. Was any of this surprising? Did I miss something? Is there something else you want to bring into this space? And you can also definitely add any comments or questions directly on the Padlet. So let's go ahead and get this breakout room set up. Any questions? Oh, did you already launch them? Maybe you're going to get swiped away. Let me know if you have questions. Awesome. Thank you to whoever did that. All right, looks like we have everyone back. So thank you all for taking the time to be in small groups together. I would love to hear just from 2 or 3 groups, what did you talk about? It can be anything, even if you went totally off script. Just want to hear what you guys talked about. Anyone wants to share?
Well, I'll share one that I shared in the group, and the group told me to put it in the chat box, but
Yeah.
it's too much writing for me. So I was surprised in the timeline not seeing the Great Depression with everything that's going on with the opioid with the opioid crisis and the mental health crisis. So I was surprised not to see that in the timeline, and also not aligning the COVID, the pandemic, with the Great Resignation, because that's also a social determinants of health. You know, what are folks doing, where they play, live, and work. So all of that, it struck me that it wasn't on the timeline, because that's our public health right now. So
yeah, I'd like to add my 2 cents worth.
Yeah, go ahead.
Can I go ahead? Okay. So it appears that was a great timeline. It seemed that the issues at each time of your timeline, it became no longer a public issue, meaning a health issue. There were other factors, I'm sure, that affected decision makers that didn't have the qualifications to make decisions. And even the health people themselves admitted that they didn't know the solution, but they were willing to find out. So there was maybe a lot of misinformation that was being spread, and it didn't help matters at all. So it became, when you say a health issue, it's a mental issue as well as physical, as other attributes as well. So, and it became a global issue. So there's so many variables that made this such a complex issue to deal with, But here we find ourselves in a similar position. And yes, we do have the World Health Organization, but because it was established, what advances have we made since then? So I just question that. And, a very simple point would be, so certain countries have great vaccines. Why don't we distribute it? What's the issue with the distribution of it? And so we get into issues that are non-health related again. And how do we address those issues?
Yeah, absolutely. And I think, Alan, you absolutely nailed where we're going next, which is what does this mean for us, right, as a global entity? How do we take some of these lessons and some of these things that really, became more complicated than just disease? And how do we talk about the factors that are influencing them and making them worse? And how do we address those in an equitable way?
Mm-hmm.
Yeah, absolutely. And I'm seeing in the chat from Rosa, the group answered, history always repeats itself. We weren't that surprised. And the conclusion is that we have to plant the seed of asking ourselves questions and not rely on bad sources of information. Yeah, definitely. Love that. Other thoughts? Anything else that was brought up that you all wanted to bring in to the space?
Hope you don't mind that I jump in. So I currently work in preparedness and response for County of San Bernardino Public Health Department. And we've been on the front lines and on the back end dealing with everything from the distribution of vaccines, opening up testing sites, the whole nine. And one big thing that we have noticed with this response is that it is a public health response, but it has become extremely politicized. And we, for the first time, are being discredited as public health professionals and being told we don't know what we're doing. So we have elected officials, board of supervisors, governors telling us what to do. When we have plans in place, we have lessons learned, we have best practices that we've seen time and time again that do work. And so as a public servant, seeing that we're being told, don't think, just do as we're told, that's been really difficult. Really, really difficult to also, for those of us who have dedicated our life and career to this field, to be told that we don't know what we're doing and you need to listen to us. So getting back that credibility as well, because of the politicization of this response, is something that is going to be very difficult for us to regain and get the trust of the community back.
Yeah, thank you for sharing that, Ashley. I see Jessica in the chat. They talked about the evolution of transportation, and contribution to the spread of diseases and vaccine hesitancy. Yeah, thank you for naming that. We're actually going to get to that in the next section or next section. So yeah, thank you for bringing that in. Any final thoughts on this piece? Oh, Gina, go ahead.
I was just going to say Ezekiel wanted to say something, I think.
Yeah, go ahead. Go ahead, Ezekiel.
Yeah, I wasn't sure if we were hand raising or not. So my instinct always is to. But I think we were talking about some similar things to what Ashley was saying around the sort of spread of intense politicization and misinformation. And I guess I'm curious, because I don't know that much about this in the historical context. Has the intensity of this kind of misinformation come up before in the context of pandemics specifically? I know it's come up with other public health campaigns around tobacco and other things, but I'm curious, like in other epidemic and pandemic situations, did we face similar politicization and misinformation? And what did we do then, if so?
That's a great question. I think when we talk about the 1918 pandemic, that might get to that a little bit, but I'm curious if there are other folks who are more familiar with some of the other pandemics and epidemics who might have a more solid answer. I can provide some information in a little bit, but I'm not an expert by any means, so I want to throw it back out.
One thing I'll offer, Tanayo, is I think maybe not to the extent of COVID-19, but the response to the Ebola outbreak, like a couple years ago, I think was also super duper politicized, in part because of, once again, the racialization of where it started, and a lot of kind of like these neo-colonial powers stepping in and being like, we know how to fix this for you. And then things definitely not going according to plan, right? So I think in the global scheme, that might be an example that maybe foreshadowed, I think, some of the response to COVID. But I think it's also worth noting, right, just that there's a world of differences between the Ebola outbreak and our current situation, both due to, I think, just the nature of the disease itself. But I know that the Ebola pandemic was also really held a lot of tensions between urban and rural communities, which I think is a little, we see some of that in COVID, but it tends to be a lot, there's a lot of differences. So I'll pause there, but I hope that maybe gets to a little bit of your question, Ezekiel.
Yeah, great example. Shay, go ahead.
I am sorry, I don't know if I should put my camera on. It goes off and out, and I apologize. And I have to say, and I know that was brought up, but I want to add a little bit to it, or to accentuate it. With the, I call it the epidemics of, probably it's the wrong word, with the drug issue that we had, and especially the Black population was really touched by it. And politically, we have thrown them in jail, the mandatory sentences, okay? The minimum mandatory, or whatever that was politically, throw them in jail and jail them. And that was a big thing. Until our community came out, of course, the white population, families, when their children starting to die from drug overdoses, and then, you know, they started to get Congress there and go and advocate. And then we have a 360 that was done. And then suddenly, you know, it wasn't the Black, okay, let them die, let them kill each other, you know, and throw them to jail. Until then, when the white community comes, the families come and started to advocate for their children, and then take chance, right? But we will basically lock them and throw them out. A little of pound of marijuana, you get it in. And look at now, marijuana is legal and people are coming in mass. And another political things, and all those are new, let me see, I don't have the name again, help me with that. All the new prescriptions or the new places that are selling those drugs now, we have to go out in force and said, how about the Black people that has been in jail for the little, whatever that was found with them. And then now we're not including them in that system. But that was political again, right? And I have to give my experience, and then I'll be quiet. I got sick and went to one of the places to be seen. And when I get there, the doctor was there with his assistant, and they didn't hear me. And I heard the doctor saying that she comes to get drugs. Just there. And I'm listening. And this is a small place. They know that I could hear that. And I didn't say anything. I get out and go to the next place. When I get to the next place, the emergency room, and I was really upset because I know what was going on with me. You know, I have a swelling and I was in pain. And the lady said, the lady starting to talk to me, she was the one in charge of that place. And then I said, you know, I just came from that place, and this is what the doctor said to these assistants. And I was so upset, and she was upset. And she mentioned to me, I am so sorry that happened to you. Guess what? She was a white woman, and she said, my daughter just died of another overdose just a few months ago. And she could empathize with me. So those things politically, and I'll say this and I'll be quiet. We had a woman come in and talk to us, and she said, it's all about race. And the race guide the politics and the policy. And 400 years ago, we're still here. So don't forget that, and I know you know that. So it guides the policies, and we have COVID, we have the Black issues, we have George Floyd, we have all of that until we come here. And guys, thank you for doing what you're doing. So everything we do will help change the course of things. Thank you.
No, thank you for sharing your experience, for being vulnerable, for naming very personal inequities that you've experienced. I know words are not enough, but I'm so sorry that that happened to you. And I think something that you brought up is the idea of centering race, right? And we are going to talk about that. So I think I'm going to use that as our segue into the next section. So let's go ahead and share the slides again, and feel free to continue commenting in the chat. I know this conversation is not over. I don't want to cut us off, but I do want to keep us moving so we can get to some of these conversations. So would somebody please, brave and lovely soul, read these definitions for the rest of us? Epidemic versus pandemic. What are we talking about?
So I can read it. This is Bobby from New Hampshire. Epidemic refers to an increase. Oops, I gotta minimize you all so I can see the rest of it. Epidemic refers to an increase, often sudden, in the number of cases of a disease above what is normally expected in that population in that area. And a pandemic, pan is from the Greek for all. Pandemic refers to an epidemic that is spread over several countries or continents, usually affecting a large number of people. There is no one hard number or percent of the population that needs to be infected for an epidemic to turn into a pandemic.
Thank you, Bobby. I appreciate you reading that out loud for us. So I won't spend too long on this slide, but I just wanted to name these definitions, mostly because the lines are really blurry between pandemic and epidemic. And that means that just because something is not declared a pandemic doesn't mean it's not devastating, right? So we're going to talk about an epidemic in a moment. So I wanted us to keep that in mind. Just because something is not considered pandemic, for whatever that means, doesn't mean that it did not deeply impact certain populations. So let's keep that in mind as we dive to the next slide. And I'm going to ask for another brave and lovely volunteer to please read this out loud for us, if someone wouldn't mind. I know it's a little bit long, so would love to hear someone else's voice.
I'll do it.
Thank you.
Okay, overlooked epidemics. Virgin soil epidemics undoubtedly occurred in 1633, for example. A smallpox epidemic struck native communities in New England, reducing the Mohegan and the Pequot populations from a combined total of 16,000 to just 3,000. Smallpox did not hit communities in the Ohio Valley and Great Lakes until 1756 through 57. A century or more after initial contact with Europeans. When it did, it was because native fighters recruited to fight for the French against the British during the 7 Years' War had contracted the virus in the East and infected their communities when they returned home. Lack of immunity mattered, but it was the disruption resulting from war that prompted smallpox's spread.
Thank you so much, Florette. So what do we think we're talking about here? What are we talking about? What is the virgin soil epidemic? Have we ever heard about that terminology?
I have. This would have happened during colonial times, right? And that was the Europeans bringing smallpox to the Indian communities and practically wiped them out.
Yeah, exactly. So this theory was really posited. I don't know if any of you have ever read or seen the sort of, I don't know, documentary adaptation of Guns, Germs, and Steel, but this theory was essentially said that we saw a mass death of indigenous peoples because the Europeans came over and they had smallpox and they infected everyone and everyone died, right? So that's kind of the very basic of it. And this is true, okay? I'm not trying to dispel this theory, but it's very oversimplified. So the idea that, you know, every single colonizer that came to the Americas was actively carrying smallpox and actively infecting people that were already here really kind of erases the reality, right? So we see here the example of the 7 Years' War. So there was war, there was forced removal of different indigenous groups from their ancestral homelands. There was all of these different social conditions that were impacting the spread of these diseases, particularly smallpox and measles. But if we jump to the next slide, please. So we can see, again, social conditions can make or break a population's ability to respond to disease, right? So I think one of the examples that we talk about a lot is the Trail of Tears, which was primarily the removal of the Cherokee, but again, lots of other tribes and groups were forced off of their homelands. I cannot name them all, there are too many, and it's devastating, but just to name a few, the Choctaw, the Creeks, the Seminoles, the Chickasaws, the Miamis, all of these different groups were forced to go elsewhere. Basically, the US government said, you cannot be here, we're going to pick you up and we're going to move you. They did not care that there were children and older people and pregnant people. There was no medical care on these forced removal marches. Malnutrition, right? So all of these different things were combining to make it really easy for these diseases to spread. So we cannot talk about these epidemics or pandemics, right, without talking about equity, because what's even more devastating than just this historical reality is the fact that it continues to this day. There's a continued erasure of Indigenous people in conversations about disease, right? We look at 2020, right after the pandemic took off in the US. The Trump administration initially refused to give money to tribal nations. They said, no, we're not going to give you anything. When they finally did, the money was fumbled. It was absolutely fumbled because the government has for so long erased and murdered Indigenous peoples in this country. When the time came to work with each other, obviously there's a huge mistrust of the government for very good reason. And on the other side, the government had no idea what to do, right? So instead of this money going directly to Indigenous folks to use as they saw fit, it got lost in bureaucracy. So this is not just a historical fact, right? This is our reality. This is a present day thing that we are still dealing with, this continued erasure. So I wanted to say that because one, we have to think about race, we have to think about equity, and two, we see this with COVID as well. Disease does not operate alone, right? So that's one of these lessons that I want you to take away, is we're not, and I think Alan, you spoke to this, right? So we're not just talking about disease, we're talking about all these different things that are combining to create really inequitable conditions and to help these diseases spread. Any reactions to that? I know this is really heavy, so I just want to give us a moment to breathe before we move on. Thoughts, things that people want to name, things that I might have missed. Yeah, state funds being tied to government contracts that don't respect sovereignty. Absolutely, Ezekiel. Yeah. Give us another moment if folks want to share reactions, questions, additions.
May I speak?
Of course.
So one thing that we have noticed in our jurisdiction, of course, we mentioned the politicization of the response, and based off of lessons learned and where we had identified our medical point of dispensing sites, you know, based off of population and also equitable access, that wasn't always taken into account when our administrators of our county told us where to put some of our testing and our vaccination sites. It was more so based off of how many people we can get. What's the throughput? Not necessarily, are we reaching those that are in the, you know, low HPI zones? Are we reaching out to those who do have difficulty accessing transportation and medical services? So that became a huge issue too, with the disparities that we have amongst our indigenous populations as well as our minority groups, because it was more so put the sites where we're going to get the most throughput so our numbers look a little better. Airing some dirty laundry, just putting it out there, like that's what's happened. And it did create a major gap in working with those special populations.
And this is Bobby. Can I add something to that?
Of course, yeah.
So for us here in New Hampshire, one of the things that we actually did try to do was create space to focus on, taking an approach that used and centered equity. But because of the history of distrust with public health, when we did prioritize some of our population groups that had usually left to be last, then there was the hesitancy because, like, wait a second, why are we first now? So then it got flipped to, why do you want us to do this first now? This, you're not going to experiment on me. We're not going to be your guinea pigs. And so we had to do a lot of, teaching and health promotion on the importance of getting the vaccine because of the harm, that it could do to our bodies. And so then we also had to remind each other that this context of hesitancy, and I would call it cautiousness. I even took hesitancy out, was there because of some of the history of things that have been done to different population groups, right? And some of that, again, was supported by public health services. So we can't forget that. Mm-hmm. And it has to be a part of the conversations that we in public health have with our communities. We have to remind, and that's why I like the timeline, but I would have liked to have seen some of the other things in our timeline in public health that have led to mistrust in many of our communities included on the timeline, because we have to remind ourselves of those things so we can continue to move forward, right? And so even though now we're trying to center on equity and focus on equity, we're still having a little bit of pushback, like, why do you want to now do stuff with us first? And I don't know if anybody else had that experience, but we had that experience here, that we had to overcome that.
Yeah, I'm seeing a lot of head nods. It sounds like a lot of folks experience this. And I just want to encourage you all, feel free to add these to the timeline, right? I am one person. I cannot think of every single thing. I don't have all the experiences that you have, so throw them on there. Absolutely. Naming these are so important. Go ahead, Damien.
Thank you. Something else that I encountered with somebody who's very vocal and kind of close to me about being anti-vaccine is that he went and got his vaccine and he got side effects. So now, because there was no a nuanced conversation with him, things can happen, but it's safer to have the vaccine than not to have it. Now he's become a very vocal voice against vaccines altogether. Mm-hmm. So I've tried to sit down with him and say, there is this percentage of people who might get side effects, there is other percentage of people who won't. And then you compare that to what will happen to a population if you don't get the vaccine. And trying to explain all of these, basically, what do you call them? Trade-offs, maybe?
Yeah.
Yeah, there is always a risk. There is always a risk. It's some things are riskier than others. But I think that is also something that we could have done better, especially, as somebody already said, in communities of color who have suffered the brunt of missteps, and sometimes not even missteps, like really targeted aggression towards our communities.
Yeah, thank you for bringing that up. I think I'm going to ask you to hold on to that thought, because that's going to come back into play in the back half of this training. I want to make sure to give you all a break, so I'm going to move us through the next couple examples relatively quickly. Just wanted to kind of throw them out there. So if we can move to the next slide, please. Just wanted to name the 1918 influenza pandemic. Estimated around 500 million people became infected, and this came on the heels of a 40 million person casualty war that was really poorly worded. But essentially 40 million people, 20 million of whom were killed in World War I. So we already have this, again, devastation, loss of life, and then this disease sweeps in. A few things that we learned, getting back to Ezekiel's question, there was a lot of pushback against this, right? I think there was, to use your wording, politicized, no, I can't say it. You know what I mean. That was embarrassing. But some things we did learn. Truth and transparency matter, right? Communication matters, and especially communication from a trusted source. So that community work that you're all doing is so important. We learned about physical distancing and mask wearing, hand washing. And again, we see this repeating incident of the folks that were already experiencing social disparities and inequities were more likely to get sick and die. Let's move to the next slide, please. We have a quick video for you. We're going to talk about the swine flu. I don't know how many of you remember that. I think I blocked it out. It was like 10 years ago, and I was in middle school, and I remember people talking about it, and I think ever since then I've managed to block it out. But we're going to watch a quick video, and that will be our primer for the next half of this training. So take it away.
Been 130 cases reported in the U.S. at this point. It's spreading, albeit slowly. The Transportation Secretary says it is safe to fly, even though Vice President Biden suggested otherwise in comments yesterday. And scientists now say the strain appears to be relatively mild, but the fear and the concerns have been anything but mild. David Muir has been tracking this story for us. David, how you doing?
You know about all the fear out there, Chris. And in a sign, an indicator this morning of just how concerned the parents are, the public is to know more about flu. Take a look at the number of Yahoo searches for pandemic this week, spiking more than 8,000%. And this morning, parents are still trying to decipher some mixed messages out there.
19 states now say they're dealing with cases of swine flu. And this morning, outside Seattle, Washington, we've learned of one of the latest cases involving a pediatrician who now has the flu after seeing nearly 24 patients.
After going home, she became more ill with high fever symptoms and went to a local emergency room.
They are now reaching out to the parents of the children the pediatrician saw at the clinic to be on the lookout for symptoms. And on the University of Delaware campus this morning, 400 students suspected of having the flu have been given care bags with Tamiflu and masks.
I feel like I'm a biohazard. Everyone's wearing the masks.
Meantime, 250,000 school children are home this morning as the number of states closing schools grows. Many parents wondering, are all of these closings too much? While others have simply grown more fearful that their child's coughs could be something worse.
Hi. Hey, Dr. Goldstein.
This Texas mother told us she took her son out of school on her own.
As a mom, it concerns me because I don't want my child to get sick. So I want to do whatever I possibly can to prevent that.
For parents, the messages have been mixed. Talking about flying, Vice President Biden said on national TV, "I wouldn't go anywhere in confined places now. One person sneezes, it goes all the way through the aircraft." The administration then quickly said flying is safe. But all this back and forth of warnings have many parents wondering if the government, the scientists, know something that parents don't.
There's no scientist or public health expert in the world that has the answer yet to this very basic question. Is this going to get a lot worse, and will it get a lot worse in the short term?
And even though new genetic testing on this new strain so far shows that it's going to be a mild case, doctors warn that it's still new. It could mutate, it could go dormant, return more virulent, which is what happened in the fall of 1918. We found this graphic animation which showed what happened in just a few weeks' time when it returned in the fall, so strong, and much stronger, in fact, than it was in the spring prior to it. You can see how it just kind of spreads across the nation within just a few weeks' time. Now, no scientist out there, no doctor is saying we're going to have another 1918 right now, but what they say this image does do is remind us that an abundance of caution is still better than less caution.
I don't know if anyone else had PTSD watching that, but I watched that and I was like, am I sure this is from 2009? So I'm going to leave you with that. Think about it. Let's go ahead and take a 10-minute break, walk away from your computer, take a breather, sit with it, and we'll come back in 10 minutes. I think we have a timer we can put up for y'all. Beautiful. Thank you, Jasper.
There we go. I'm not always the biggest fan of meditation, but it's always nice to get that reminder. And then when I actually sort of like force myself to practice it, I'm reminded like, oh yeah, I probably should be doing this a little bit more. And I love when he's saying like, let your mind think, all of a sudden, like my mom brain kicks in and like my to-do list start running down and that happened to everybody else. I'm like, I got to make that appointment. I got to call the doctor. I got to pay the bill. I got to, and then I'm like, wait a minute. Focus, meditate, breathe. So yeah, so just how my brain was working in the moment. So welcome you all to sort of dive back in. As Chanayo sort of named at the end of her section, we watched this video about the H1N1 flu. And also sort of, I had a very visceral reaction towards the end when the newscaster was like, out of an abundance of caution. I was like, if I hear that one more time, between the abundance of caution, how we're gonna pivot, any other sort of key phrases that like trigger me, I think when it comes to COVID-19, that were just over and over and over again, sort of brought me back to that place and very much reminded me of all the things that we're hearing now that we're in year 2 of COVID, almost to the day, I think, when things started to shut down and we started to realize the reality that we were being thrust into. So that's where we're going to kind of pick up. COVID-19, where are we and what does it look like now? Thank you, Jasper, for sharing the slides. So we're looking at, these are global numbers, and we want you to treat these as conservative numbers because of the way that we were reporting and testing, that these are not exact, but the thinking is that it's probably more than what you're seeing on the screen. So the cumulative confirmed cases for COVID-19 are over 462 million cases, which is almost equivalent to the entire population of our country, the United States. So kind of let that sink in terms of the cases, and then the cumulative deaths, sorry, tongue twisted there with that word, are over 6 million, which is almost equivalent to the population of the state of Massachusetts, for those of you that are local. And if you're a visual person like I am, I find slides like this really helpful just so that I can envision and see like what those numbers actually look like when you think about cases and deaths. And if I were to picture sort of the entire population of Massachusetts dying of a disease, then like that for me is really striking. And sometimes it's easy to get lost in the numbers if you've not been particularly affected, or to just say, oh, these are just numbers. I can kind of push that to the side. But when you see visuals and you name it, I think sometimes it can be really striking for folks to see and think about in that way. And so that's kind of our situation. That's where we're at with COVID in terms of numbers and how we use that to guide our thinking, and where we are, year 2, right? We've been living this, we've been doing this. If we move on to the next slide, we want to share with you some more sort of COVID facts and numbers in terms of COVID cases by region. And so you'll see kind of circled on this slide the numbers for the Americas. And when we say the Americas, that does include North and South America. And you'll notice that there's a red arrow on this slide too. We just wanted to name and mention the fact that the Americas are kind of following the trends that are happening in Europe. If you notice sort of the ups and downs of our sort of orangish bars are following the same as the green above it, which is Europe. And so we can kind of see those same trends in our country as well, and the way that the numbers are playing out. And so keep that in mind as we start thinking. So we're trying to figure out how we're learning, right, from this history, this rich history that we just talked about, right? And now we've been thrust into this pandemic that we're living through right now. And so we're learning, where do we land in the context of the rest of the world, and how is it looking for us here? What does that mean for the way that we're engaging our communities and having this conversation, right? So we're seeing these trends, we're sort of in the moment thinking about the deaths and the confirmed cases and how it's impacting the communities. and how it's impacting the public health field, right? In the beginning of this training, I forget who it was, somebody talked about it feels like one of the first times that we've been questioned as public health professionals. We are not the expert. We don't know what we're talking about, and there's lots of misinformation going on. So it's important to name sort of the context that we're in and how we're being impacted and the trends that are happening across the country and across the world. So I'm going to ask Jasper to bring us to our next slide. And these are deaths by region, and you'll notice that there's a switch, right, in our country, that we are now leading the world in deaths in the Americas and what that means. And so the trends are the same, but if we're looking at the impact that history has had specifically on this country in the United States. Thank you, Rosa, don't worry. Appreciate you and the time that you've spent here. If we look at the impact, right, that our country has had on the public health landscape, and we were talking about the mistrust and distrust that our communities have of our government. For some folks, this trend and what we're seeing in this country is not surprising, right? The fact that we're leading in deaths by region in the Americas, right? And so what does that mean for our approach? What does that mean for our work? What does that mean that we now have to combat the mistrust and distrust in the way that we're connecting with communities? So those are some quick numbers, some quick slides, just to provide some context of kind of where we are at with COVID-19. Does anybody want to add anything in terms of, yeah, just what you're seeing out there and how folks are responding to you for those that are doing work specifically with COVID? All right, I'll take the silence as hint to move on. So we're going to go to our next slide. Awesome. So this, again, no surprise to anyone here. We are calling this sort of local context, the color of COVID, that communities with lack of access to the following are more vulnerable to COVID-19. We talk about the social determinants of health a lot in public health, the environment that people live, work, and play, and that those impacts make them more vulnerable to disease in general. And that when we were hit with COVID, we started to see that in the communities that we are working in, specifically Black and Brown communities, were more disproportionately impacted by COVID because they are sort of dealing with the social determinants of health. And when those are lacking, right, and because of the systematic racist policies of our country, they are more impacted by COVID-19. And so you start to see some of the trends that we see that we're seeing now, right in life, in the work that we're doing right now. And I want to name and call attention to this next slide, actually, to speak to some of the folks that were talking about our timeline and the things in particular that we were missing. So there are some very historical sort of things that were happening in our country that led to the mistrust and distrust of the government, the public health field in general. And that timeline that Tanayo shared could have been 3, 4, 5, 20 pages long if you start to think about all the really important public health things that have happened in this country in particular. And there are things like the Ebola pandemic that you all raised up, I think that Jasper mentioned, right? If we think about the drugs epidemic that we're facing in this country as well. If we start to think about things like what happened in the Tuskegee experiment, right? That folks were intentionally, specifically Black men were intentionally told that they were going to get treatment for a disease that they didn't get treatment for, and they were impacted, and a lot of people sort of died. And when we think about the history of birth control in Puerto Ricans and the way that women in Puerto Rico were sort of tested on as well. If we think about the history of Henrietta Lacks and the way that her DNA was stolen by doctors and medical professionals, and her family was not sort of aware or compensated for that as well. So think about all of these instances, and this is just like a small list. There, like I said, there could be 10, 20 pages of all of those things that are happening in our country. So what does that mean? what does that mean for the work that we're doing and for the way that we look at our work? And so we're going to dive into an example that we have that's housed within Health Resources in Action, but I just wanted to name that these are the real impacts that we're seeing when we're doing COVID-19 work. And this is just our way of thinking through how to combat that distrust and mistrust of the public health field, right? And this is not to say that this is the only answer or this is the perfect answer. This is just one way of doing this work. And that as we move through these next slides and this next conversation, we want you all and invite you all to be a part of this conversation of what you're seeing in your communities, to bringing in your own strategies, thoughts, ideas, because that's what I love about, in particular, these spaces and bringing public health folks to the conversation like this. And so when we do small breakout groups, when we open it up to the large group, the way that we have this conversation is going to be really important because we want you to contribute to this. This is how we move forward. This is how we break down the silos and prevent the repetition of history. Right? When we bring all of our strategies, our best practices, our really creative ideas of how to impact the inequities that we're seeing in the work today. So I welcome you all and hope that you feel sort of, continue to feel sort of empowered to share in this space and to take space as we continue to have this conversation. And I know it comes right when we get close to 12 o'clock, there are a lot of people that jump off. We recognize that. And so appreciate those of you that have stuck with us. And if you have to leave, we will miss you. But at the end of this training, not only will we send out the feedback form, we'll send out the recording of this training, we'll send out the slides, the list of resources, all the Padlets and things that we've shared today as well. So you will get that at the end of this training, maybe not right at the end, but you'll get it within the week or so. So be on the lookout for those as well. So any thoughts or questions before we dive into talking a little bit about the work that we do here at Health Resources in Action? Looking around, giving some time to pause. All right. So we're going to move on to the next slide. We want to talk about the HRA, our organization, our health equity framework. And this is sort of the framework that we use to think about the work that we're doing. And the way that we talk about this is in these three little bubbles. So we have this really cool visual here that talks about, sorry, I've got two screens, and so I'm going to be looking over here, but I know that I'm talking to you all, and I've just recently got two screens, so I don't know how to act with all the information and all the screens in front of me. But when we're thinking about implementing programming, building programming, trying to figure out what it looks like in what it looks like in the work that we're doing, we try to pick up this lens and really think about and think through these three different pieces. How do we challenge, right, the assumptions and narratives about what promotes and hinders health? So we know that we have a history of excluding certain populations in certain communities. So with that framework, or with that challenge in mind, when we're thinking about doing work, whether it's in the COVID-19 space, whether it's in the anti-violence space, whether it's in building capacity for different coalitions, whatever it is that we're doing, we're coming in with the idea of who is at the table and who is missing. How can we challenge the current narrative, right? And ask those questions and figure out, okay, how can we get over this to make sure that we're centering the voices of the people that are most impacted by whatever it is that we're trying to do or whatever it is that we're trying to implement. So that's the first kind of step of our health equity framework, is about that challenging space. And then once we've kind of asked those questions and start to figure out who's missing from the table or what voices we want to center in this space, we want to think about how do we engage them in this process? What does that look like? How do we create and sustain authentic and diverse engagement? And that's going to look different depending on the community that you work with. And so this is what you'll notice. This is going to be a broad framework. So when we're implementing this in the COVID-19 work that we're doing in the city of Boston, is going to look very different than the work that you're doing in your location with your population. So just want to posit that there as well. So really thinking through, what does authentic engagement look like to the community that we're working in that specific population? How can we think through what that looks like? after we've thought about who's at the table and who's not, and what are ways that we can engage them authentically, then we start to build, right? We start to think through strengthening their capacity, correcting power imbalances, really naming that oftentimes when we come in as an organization, we've probably been funded to do some sort of work, either by federal funds or state funds, or we're bringing in our own monies or our own dollars thinking of doing this work. That comes with power. So what does that mean? What are ways that we can then shift the power, the decision-making power, the voice power, to the communities that we're trying to impact or work with, right? We've challenged ourselves by asking the questions. We are thinking through ways to authentically engage community. And part of that conversation is handing over some of that power as well, so that the community can see that they are also involved in this process and in this work that's happening. So that's kind of a quick overview of our health equity framework. And just want to sort of name, are there any thoughts or reactions to this? Does this make sense to folks? Or if you're just like, I've never thought about it this way, or like, yeah, we do this too. This is what it looks like in our organization. I see some thumbs up. Thank you. Other thoughts and reactions? Yeah, I see some head nods. Anybody want to share similar work or any challenges to this framework at all? How have you thought about it in your organization if you are doing this work or thinking in this frame?
Gina, I want to share a quick thought.
Yeah.
For me, it's easy to put the equitable lens, but it's exhausting to get others to see through those lenses. You know, I'll share a quick example. Last week, we had our Patient Family Advisory Council meeting, and it's a pretty diverse group. And one of the patients expressed an incident that happened. And of course, it's unfortunate that it was a person of color who had a bad experience on our hospital grounds. However, now the meeting's over and the staffs are now meeting. How do we address this issue? But it's just exhausting to see that. I'm like, well, we really need to engage the folks that are who continue to. I don't want to discredit anyone, but sometimes the way we handle situation is not the most sensitive to what people encounter. So I guess my thought process is not everyone is really utilizing this framework, and how do you get others on board to change, to, you know, take off the lens they're using it and try to use some other ones. I don't know. I just struggle with this because I'm exhausted, and the pandemic got me even more tired because I feel like now they call out more to the individual. Oh, like these are your folks, or this is happening to your community. You know, like, so I'm not all things for everybody, and so I don't know. I wanted to throw it out there because I don't want to make it sound like everything's perfect.
Oh, yeah.
We're living in a perfect world. And so these are the challenges and struggles that I face on a daily basis. And so I guess I wanted to find an answer. Like, how do we continue to engage others to follow this roadmap? That's it.
I would love, thank you, Rosa. I think it's an important question to ask, and particularly if we're encouraging folks to include the voices of people that are most impacted in the organizations that are working with them, right? If representation matters, and if we are asking organizations and folks in public health to do that, we also need to be paying attention to the burden that places on folks of color and people that are at the table that are sort of representations of the larger community. And so how do we do that? How do we take care of the community and also taking care of the providers that are in those spaces? So I open it up to you all. What what are you seeing? What are you experiencing? Do you have similar reactions as Rosa? Are there things that you're doing that you found have worked for you? It's so funny, we had a similar conversation. Part of the other work that I do at Health Resources in Action is through the BEST initiative. And so I work with a lot of youth workers and we do a lot of youth development trainings. And we just had a similar conversation yesterday where youth workers were like, I am working with traumatized young people, but their trauma is my trauma because I've gone through it as well. So how do I take care of myself while also creating space to take care of them too? Go ahead, Vanny, you raised your hand.
Thank you. I just wanted to echo Rosa's sentiment around being exhausted to do this equity work. I think like one of the obstacle in thinking about this framework is often presented as a top-down approach. So that sort of loses the buy-in from community. I want to share one success, and there are some challenges, but success that the City of Revere is doing in our community health and engagement department. We have a small group of folks who are community health ambassadors that was transformed from being COVID response ambassadors, and that was recognizing that we are, in order to reach our most marginalized community members, we needed representatives who were able to be trained and already may leverage their own access to the communities. And so I think that has been a really successful part in our program or in our department, is being able to reach people through community leaders under this ambassador presentation. And I think it's been successful. There are some challenges to that because we still are not going to reach everybody. I think that it's hard to hit all groups of folks and really be as inclusive. But I think the more we move towards recognizing, centering the most marginalized community members and empowering those community members, and I'm speaking not just like in the context of training, but also compensation, that reduces this need to value proposition, the health equity framework, this because I think then it becomes understood across the board, but because I think that's being worked on in a parallel stream. There's a lot of energies to Rosa's conversation earlier, just recognizing it's a lot of work for BIPOC folks to continue to advocate for themselves in this space and do the work. But I think, again, I want to also land on a positive note is now we have a multilingual, intergenerational team of folks that are out there reaching our communities beyond social media, beyond screen, and meeting people where they're at. We see and we can hear more vaccine hesitancy when we have folks on the ground versus like trying to figure out just from the data, right? Like what's being collected. So I'd like to just offer that this that the city's department having these ambassadors has been significant in terms of us addressing COVID and dealing with the responses in the city, and just really grateful for being a part of that team.
Awesome. Thank you so much for sharing. Yeah, go ahead, Maria.
So what the challenge is, obviously, for Malden as well, was that we were named as one of the 20 communities in Massachusetts that had the inequity in our COVID response and vaccination. So we were fortunate enough to have the access to all of the COVID vaccines that we needed. That being said, we were the challenge was to locate the population where the population could best be served. So we had maps done and really kind of tried to figure out where the pockets of the population were. So we had some housing projects in Malden, and there are we're very ethnically diverse here in Malden, and it seemed as though the housing projects were really where most of those were not, most of our residents were not vaccinated, as well as we have a warming center in Malden. We also have a few Haitian and Brazilian churches that are not, that were obviously people of color and people that maybe had language barriers. We had all our, so we had some, quite a few vaccine clinics located right at the community rooms at the housing projects, which went very well because we had them advertised through the social workers at the centers, at the housing projects, and we had them right in the community rooms there. We had all the information done in multi-language, all the languages that we know are popular in our city. And then we reached out to the Haitian church, the Haitian, we were lucky enough to hire sort of an outreach worker type community engagement who is multilingual. We were able to have her speak to the Haitian community and got a lot of people on board that way. We went to the Haitian Adult Daycare Center. So we kind of found a bunch of areas and we worked with the with those different communities and built up a partnership with their leaders. And we're able to do quite well with that. With the extra resources, door knocking, people within the areas of the least vaccinated. So, you know, I think like was talked about earlier, you know, people getting right out in the community is very beneficial, as well as getting the leaders of those communities on board and having them speak. We also did virtual town meetings and had people that's, you know, from their leaderships, you know, we did them in different languages, and those seemed to work out well, and we got people on board from there. So there was a lot of, you know, different ways. So we had to sort of dive into, you know, to engage the communities that were hesitant, and then to build sort of a, you know, trust and capacity with those individual different ethnic groups, I guess. So, and we did end up with a really good vaccine rate, but it's exhausting. I agree. It's exhausting, and it's really kind of thinking outside the usual box that we have, you know, to get people to engage and build that capacity and trust.
And not only that, thank you, Maria and Vanny, for both sharing your experiences and some of the successes that you've seen in your work. And I think to layer on top of that, not only sort of like trying to engage community authentically and really thinking through how to battle through those problems, we layer on the spread of misinformation, the impact of social media on the populations that were not, like, all the things, right? So like we're battling all the things and also trying to sort of implement frameworks like this, because we know that history has taught us a lot of lessons, and we know that this is where we need to put our energy, and acknowledging that it's a lot of work for people to think through, especially when you are in the communities that you're trying to impact, that you are a member of that community as well. So it has layers of impact is what I'm going to use your example, Maria, as kind of a segue to talk through the Massachusetts COVID-19 Community Grants Program that we have here in our organization, because there are a lot of similarities there as well. So I'm going to ask Jasper to take, or Kelly to take us to our next slide. I think Jasper had to go out, I think. I'm not sure, actually. Anyways, I want to talk through our COVID-19 grants program. We are a partnership between Health Resources in Action and the Massachusetts Department of Public Health, a lot of state money that has gone to this program in the last couple of years. And the overall goal for this program is to invest funds and capacity building support in BIPOC communities hardest hit by COVID-19. So as Maria alluded to, there were identified communities that had that were disproportionately impacted by COVID-19. We know that that's probably because of all the social determinants of health that are already existing in the environments that folks are living in and working in. And then adding the layer of COVID-19, we know that folks didn't have access to testing, to vaccinations, to really solid, reliable information. And so that's where we wanted to put our money towards. We wanted to fund communities so that they can help us do this work, because we know that when we employ and put our money towards trusted community leaders, that folks respond to them better than they would the government or public health professionals, because of our, our sort of racist and our racist systems that we have in this country. So that's what our program is. We funded over 75 community and faith-based organizations, including tribal and indigenous servant orgs, to deliver culturally and linguistically, which you talked about, Maria, too, appropriate COVID-19 vaccine information. So getting the word out through trusted community sources, through churches and community organizations, folks that were living, breathing, and connecting with the community, and that people knew who they were. And so they were going to trust that information from them. And we wanted to fund them to do that work so that we could have a real impact in the communities that were hardest hit by COVID-19. So that's part of the way that we were kind of challenging the narrative, right? With all this information that was happening in the media, through the government, through the CDC, it was hard to figure out who to believe, when, where, and why. And so part of the challenge, part of the framework is saying, we want that information to come from those trusted community sources, and challenge the narrative of like, oh, you can only get it from your doctor, you can only get it from the government. We wanted to empower folks to get the information right in their communities. I'm going to ask to go to the next slide and think through sort of that equity as a process and an outcome, right? And so if we're thinking through the equity lens, we want to challenge that narrative. We know that in order to impact those communities, we want to make a real concerted effort to engage them in this process. And so we're doing it, and we're putting our money where our mouth is in terms of these grants, right? And also making sure that we're questioning and challenging along the way as well, because we're learning too. COVID-19, as you all know, every week there was something new to deal with, or another update from the CDC that we then had to interpret and figure out how it was going to impact our work. So we were constantly sort of changing and trying to figure out what the best approach was as well, and thinking through, asking ourselves, how do we create a program that challenges commonly held assumptions and narratives about what promotes and hinders health, right? How are the root causes of inequities? What are the root causes of those inequities, right? And so taking a look at that history, really understanding what was impacting our communities, and really taking a look at how racism was operating and naming that. Right? When you name that we are a product of our racist structure, and that we need to really pay attention to how it's impacting our Black and Brown communities, and then saying, okay, we're going to do something to counter-react, that's that challenge, that's that question. And we not only need to ask it at the beginning, but all throughout the process as well. I think we're going to go to our next slide. Engagement was all about engaging the community. So how are we creating and sustaining that authentic and diverse engagement? Who is benefiting, and how are they benefiting, and what are they included in that benefiting process, right? And so when we were thinking through who to fund, who was available in the community, we put the call out to everyone and anyone, and there was an application process that people went through, and we wanted to see that folks were really invested and engaging in community, and sort of how they were engaging with community in a way that we could sort of gauge that, okay, we're going to put our funds and our grant funds in this specific space because we can see that they're a member of community, folks are going to this church, or they're a trusted organization that folks are engaging with on a daily basis. And so we think that folks will respond to these folks as they start to give out vaccination information, COVID-19 information and testing, and that they'll have a really successful turnout when it comes to engaging community authentically. Next slide. And then continuing to build and lead. Who's leading in this process? Our grantees are leading in this process. We have really tried to think through ways that we can hand over power by making sure that their voice is at the forefront. And so part of our process and the way that we've kind of been thinking through this as well as a program, as a project, is that because there's constantly new information, constantly changing information, not only are we sort of inviting them to the table, allowing them in the decision-making process, they're also helping guide us. So they're telling us what are the challenges that are coming up every week, what's working, right, that we need to continue putting our effort towards, and also sort of any other trends that we're seeing in the field of like how populations are responding, questions that folks have, challenges that are coming up, just like how can we make sure that we're continuing to center their voice so that they're helping lead us into bringing that back to our funders and saying, this is what's happening in the communities, we need to respond, or we need to figure out a way to support some of those challenges as they come up, right? We don't know what we don't know. And so ways that we can continue to center that community voice and those players that are on the ground, the better, because we are not there. So we don't know what we don't know. And so when we're able to highlight their concerns, their challenges, their strengths, things that their successes, we want to put our efforts and our thoughts to that as well. And so we're in year 2 of doing this work. And we've learned, as I'm sure you all have as well, we've learned so much about the way that we are connecting and engaging with community. And so I think at the beginning, it was really about getting the right information to people, making sure that folks had access to testing and vaccination. And now I think some of that has shifted a little bit into like, Rosa, you were mentioning, like people are tired. It's been a long 2 years of COVID-19. And so what are ways that we can continue to be creative about engaging communities in some of the solutions so that we can start to think about what it looks like on the other end of COVID-19. So that was a really, really quick run through of our slides. And I do want to get you to your breakout room because we are going to be giving you a chance and an opportunity to think through your own strategies. But before we kind of set you up and send you off, I just want to give folks a chance to kind of respond and react to that very quick run through of what we're doing kind of on our end and how we're thinking about this. Any questions that folks might have about any of this?
I don't have a question as much as a comment. I think it's what's been presented here is excellent. And you know, in all the areas, you're doing a wonderful job, all of you. What I'm concerned about is it's not you internally, people are doing their work. What concerns me is the work is getting out voiced by those who aren't given the right direction. And that I'm so frustrated because no matter how much good is done internally with the actual process, if we're getting, you know, the message as you spoke to, is we're constantly being swung into another area, being discredited, where in the past, the public health professional and professionals in general seem to be given some respect, so to speak, or, you know, looked upon as, but now that's gone away. And I know you're trying to reinstate that, but it's still a problem for me, is what I'm saying. It's still a problem. And I don't, and I just wanted to raise that because I'm thinking we need to put some energy into that specifically to gain back our professional expertise in the communities, the voice of it anyways, yeah.
Thank you so much, Christine. I see Dora in the chat box says, I think part of the challenge is also reinstating the trust in public health professionals, which is exactly what we're trying to figure out what that process looks like. And we're in the middle of doing it as well. It's just like, how do we do that? What does that look like? Was there somebody that unmuted that I might have cut off? I wanted to jump in there. Yeah, and I think so. I think we're right there with you, Christine. It's really trying to think through what are ways that we can bring the trust back as public health professionals. But I think part of that process is also decentralizing ourselves. Like, we don't need to be the experts. I think what we're saying is that we want to uplift and centralize the communities because they're the ones that are the experts of themselves. And so if we are working with communities that are disproportionately impacted by the effects of COVID-19, and we want them to have the most up-to-date information, we need to hand over that power. We need to give them all of the resources and that we have at our hands and allow them to engage in a way that we just won't be able to, because we're not in that community and we are not representatives of, you know, of that struggle that they're facing. And so when we're able to hand over a little bit of those resources and that power, we know that that's most effective. Our data is telling us that that's most effective in the way that we're doing this work. So I think it's a constant struggle, and we want to continue to do good work as public health professionals and as a field. We want to continue to advance and allow that that expertise and that knowledge to spread and share some of those reins and power as well. I think it's a balance to try to figure it out. So thank you so much. I'm gonna set you up for your breakout rooms. We're going to give you some time to answer these two questions. You can answer both. You could answer one. You can respond to all the things that we've shared today. You can really kind of do your thing, but really what I hope is that you're inspired to share, continue to share some of the strategies that you're working on, the best practices that you've instilled, the things that you've learned over these last couple of years doing work in community. We want to hear it all. So the two questions that we've posed here are: what innovative health equity strategies have you seen or heard of to address COVID-19 impacts? And how are you currently integrating a health equity approach in your work, or how could you? Is there anything that you wish you could be doing that you think would work really well? We are hoping that you all can take advantage of this next Padlet. Thank you, Tanaya, for adding that into the chat box. And take notes as you're having a conversation. And the way that you can take notes in the Padlet is by clicking the little plus button on the bottom of the screen and just adding a note there. So those are the two questions. And I think we added the questions, or let's add the questions to the chat box too, actually. Oh, they're already in there. Psych, I lied. Thank you, Kelly. For doing that. And so I think if we're ready to go, we can send folks into breakout rooms. We'll give you about 15 minutes or so. Awesome. Thank you so much for coming back. Apologies. I know that was not enough time to have that conversation at all. And glad that you guys jumped in there. I saw some folks typing in on the Padlet that we shared some of the strategies. So I encourage you all, if you didn't get a chance to do that in your small group because you're busy chatting away, feel free to do that now. We can drop the link in the chat box again, but want to make sure folks have an opportunity. One of the things, both with this Padlet that we just shared, the one where you're sharing strategies, but also in the timeline Padlet as well, if there are things you want to add, we invite you to do that too. We want to make these living documents, things that are representative of the conversations and the space that we're holding here today. So in order for it to be a shared resource, something that we're continually building on and learning from, invite you to do that as well. So some of the things that I'm seeing on the Integrating Health Equity Padlet is thinking about ambassador programs, right? Understanding community influence and the intergenerational gaps in regards to messaging. Folks are sharing that using a culturally responsive and expansive lens in regards to communication strategies is really important. Hiring from with the community that you're working in, and also sort of an attachment to that, not only filling a position for the sake of filling it. If you're not reaching the community that you're trying to hire from, allowing changing your strategy, right? If you're not getting the candidates you want to get, don't just hire from the pool that you have. Go back and see what are other ways that you can reach the community in a way that perhaps you haven't tried before. So are there any other strategies or any things that came up in your small group conversations that I didn't just read from the Padlet? Are there any other things that you all want to bring into this space and highlight and share with the larger group? Thank you, Liv. Appreciate you.
So one thing that I had mentioned in my group that in San Bernardino County, which was a huge feat for us, was
the coordination with our faith-based organizations. Because we do have a very diverse group here in San Bernardino County, we were able to work with the Catholic Diocese and the bishop himself to get approval for a blanket memorandum of understanding to utilize all of the parishes in our jurisdiction for testing and vaccination sites. So that's huge, huge for us. Also working with African American churches, that took some time. That took some time working with them and explaining to them the importance of working with their community and showing the data and stating that, you know, your congregation is at risk. And we do see, you know, higher incident rates within African American communities. So it would be a great opportunity for you to help and save lives of people in your congregation. So we had to take a step back with them and really do one-on-one relationship building that rapport, that trust again. And luckily we were able to secure MOUs and open up sites. And it made a big difference in our numbers, working with those that are in the low, you know, HPI zones as well.
I think you bring up a really great point, Ashley, is that oftentimes I think in the public health field, because of the nature of the research in this field, oftentimes we don't see the ramifications or the implications of what we're trying to do, the strategies that we're sort of implementing in our communities until years down the line. But the truth is our communities can't wait years for us to like really be creative and have an impact. So the stories that we collect from the people that we're working in, that is data. And we need to bring that to the folks that are providing the funds for this work and highlighting those voices. And I think that's a perfect example of the way that we can be like, listen, this is what's working or this is what's not working. And we won't have the numbers to back this up, but you need to recognize that because this is coming directly from the community, that is a really important data point that we need to highlight and raise in doing this work. Thank you. Any other last thoughts before we kind of slide into our closing? I see folks typing into the Padlet. So we'll share this link to the Padlet as well after the training and include it in our list of resources so you can go back and revisit some of the strategies that folks are sharing as well. Awesome. Thank you, Bobby. I appreciate you all spending the time. I know it's a long time to be staring at a screen for 3 hours and listening to folks talk at you, but I appreciate the time that you've spent sharing your experiences, sharing your strategies, your frustrations in this work, and hope that you can continue to engage with us. This is a quick slide of resources of some of the things that we've shared today and that we will share in a follow-up email that has all this information as well. So I encourage you to click through all the stuff that we've shared today and to revisit this information so that we can continue this conversation. As you know, CHTI, us as a project, we've got lots of different things coming up. So we encourage you all to come to our next set of trainings where we're having a two-day kind of two-part training called Reimagining Safety in Our Communities on April 5th and 6th. April 5th and 7th. And that will take place online as well. So please visit our website, hrainstitute.org, sign up for our newsletter. If you are not already signed up, is where you get all the latest information about all of our resources and trainings that we have coming up. And then we'll leave you with our feedback form. As I mentioned at the beginning, we love to hear what you thought of this training, what could be improved, what worked, what didn't work, what other trainings you might be interested in. So we'll give you a couple of minutes to fill out the feedback form. Now, let's see if we can get the link in the chat box for you. And it will only take a couple of minutes to fill out. Let's see. Aha! There we go. So it is a SurveyMonkey feedback form. And as soon as you turn it in, I think you're free to go. I want to thank you all. Thank you, Tanayo. I don't know if you had any closing thoughts or words that you want to leave folks with for today.
I'll keep it short and sweet since I talked at you for a long time, but thank you so much for coming and engaging and sharing your expertise and your thoughts and reflections. Really appreciated the space today.
Again, we'll leave you some time to fill out that feedback form. So we'll kind of hang out here. So if you have any thoughts, questions, things you want to share, please feel free to do that now. This is kind of our our closing situation. Again, thank you so much for your time. We appreciate it. I'm always always speaks a soft spot to my heart when people actually show up and stay and listen and engage in a way that kind of feeds the soul and feeds this work. So I appreciate your time. Thank you. Thank you all so much. Take care.